Hello, and welcome to Leadership PRN. This is the Dalhousie Faculty of Medicine podcast for leaders both established and emerging. My name's Dr. Lara Hazelton. I'm a psychiatrist in my clinical practice and one of the directors of faculty development here at the Faculty of Medicine. Today, I'm very pleased to have with me Dr. Joan Sargeant. Hi, Joan.
Hello. Thank you for the invitation. Great to be here.
Joan and I have known each other for a long time. We've worked together in continuing professional development at the medical school. And when I was doing my Master's of Education, she was my thesis advisor. So,
Oh, my goodness. How many years ago was that, Lara?
it was about, I think, 2012 or something like that. So
I was thinking about 10 years, 12
Yeah.
years. Yeah.
So it's great to have you here today. So I know all about you, but why don't you introduce yourself to our listeners and talk a little bit about the work you've done in continuing professional development?
Well, thank you very much, Lara. Let me think. I think it was 1995, which seems a very long time ago. That is just about 30 years ago that I began my work that time in CME. And at that time, I was involved in a project. The province had just initiated telehealth and video conferencing, which now in the age of Zoom and the internet, sounds really, really foreign. However, in my education degree, I had been studying what was called distance education at that time, and so was taken on to evaluate this new and innovative project for video conferencing, for continuing medical education, and for telehealth. And my background prior to that, I began my career as a nurse, and a nursing instructor, nursing educator, so quite familiar with the healthcare system, and then carried on with continuing education in education and then medical education. So that was my entry into the continuing medical education. And then from there, I certainly became very interested in a number of things, as it was such an interesting field. And the one that really sort of twigged my interest most was really learning more about how physicians learn and how they're assessed in their practice. That I became very interested in assessment, partly because it's so critical to knowing how one is doing and where one needs to go and what one needs to improve. And so that was a big interest. And at that time, too, I'd been invited by the College of Physicians and Surgeons of Nova Scotia to become involved in some of the assessment work that they were working on. And I think, we realize it's a double-edged sword that when physicians get a letter from the college, for example, it's very anxiety-producing. So I was really curious about how can we provide performance data to physicians and assessment data to physicians and without that huge anxiety, and how can we learn to make it more helpful? So that was one area. Another area that I became very interested in was the teaching of communication skills, and how communication skills can be used to enhance patient practice. Another area was interprofessional education. And I think this still remains an interest as healthcare becomes more complex. How can we learn more about how teams work together and how they communicate, and realizing it's not just physician education, but the healthcare team education that we want to work on. Oh, and then the physician assessment work led into a series of studies and led me into extensive research, both around self-assessment and around providing feedback. So as I mentioned earlier, I'm very curious about how we can provide performance data or feedback to physicians and healthcare teams in a way that they will be accepting of it, understand it, and take it on to improve their practice. So that led to a multi-year and multi-site program of research in assessment, self-assessment, and feedback. And this culminated in the development and testing of the R2C2 feedback and coaching model. So where did R2C2 come from? We learned through the research that 4 factors seem to be critical to feedback acceptance and use. The first is relationship, and the second one is reaction to the feedback. And the 2 C's are the content of the feedback and coaching. So hence R2C2. I'll say a little bit more about each. The relationship between the supervisor and learner, or between the facilitator and physician, is the essential ingredient to a successful feedback conversation. Learner trust in the supervisor and their belief that the supervisor has their best interest at heart are critical to the learner's accepting and using the feedback. And the learner having trust and having that trusting relationship can even enable very difficult feedback conversations. The second R is reaction to the feedback. What does the learner think of it? Do they agree with it? Fostering learning about the reaction and reflection upon their feedback and hearing the learner's views has been shown to increase their acceptance of the feedback, especially when the feedback is inconsistent with the learner's own views. Moving on to the C's, the first one is content. Content refers to what is the key message in that feedback. What is the one thing that both the learner and the supervisor should agree to that would be the topic or the object for improvement. So finally, once that agreement is reached, we move on to the coaching phase and helping establish and identify the goal for change or improvement. What is that one thing to work on? And what is that one thing that the learner should achieve in relation to that? Coaching means guiding a learner in developing a concrete plan for implementing their improvement. And this is the phase that we found where faculty have the greatest challenge, as it doesn't mean telling the learner what to do, but facilitating their development of a concrete action plan. And this is an area where we all, as health professionals, physicians, and educators can increase our skill in coaching and facilitating the development of learners and those around us. I think I'll stop there and see if if you have other questions or if that's what you were thinking of.
Yeah, well, I mean, certainly your work in assessment and the R2C2 model has been very widely adopted.
Yes, you're right. We're certainly. Yes, we've been certainly gratified that it's proven to be a helpful and practical model, that it's not just been research for the sake of doing research, and that we've learned it's being used in certainly in a number of undergrad and postgrad countries or programs. Undergrad and postgrad programs here in Canada, and in the U.S. The Accreditation Council for Graduate Medical Education in the U.S. for their resident education has adopted it as a model for their faculty development for program directors. And it's being used in about I'm just trying to think about another 15 or 20 countries. I've sort of lost track around the world, and translated into about 8 or 10 different languages by now. And so it's just heartening to know that it's a model that's helpful. And I think part of it is that, the depth of the research that we really, we had an international team of researchers. We had a variety of skills on the research team. And so I think it sort of adds to the credibility of the work that due to the rigorous amount of research that has gone into it and study that's gone into it, that it adds to the credibility of it. And it seems to be a model that makes sense to people and that they can use without too much difficulty. One of the biggest pieces that we found around it is giving that pause to reflection, whether it's a physician who's receiving their formal performance feedback from their college or wherever, or whether it's a student or a resident, that often, especially, I think we've all found, if we get feedback that's what we call disappointing in some way or another, we tend to have an emotional reaction to that we can, react negatively, we can be sad, we can be angry, whatever. And so recognizing that in that feedback conversation and giving the recipient of the feedback a little bit of space just to reflect on that, how does it make you feel, and why, and did you think something different? Maybe you thought you were doing something in a different way or in a better way or whatever. And so giving them time to reflect on that and just process all those feelings. As we know, when we're emotional about something, it's hard to move to the next step. It's hard to move to action. And so helping them sort of process those, with statements, that we often use, empathetic statements. Yeah, it's hard to hear this message sometime, or, I felt the same way when I heard that, whatever, just to help them know that they're being heard. And then that enables them to move to the first C, which is the content, focusing what is the most important part of this feedback message, the part that gives you the most opportunity for improvement. And so helping them to focus on that, one thing ideally, or no more than two, and then beginning to have a conversation about how they can use that content and that feedback to change their practice, improve their practice. And not just sort of saying, well, yes, that's what I've got to do, and I'll go off and do it, but helping them to set a specific goal. So if what thinking of something that has come up around, perhaps more often with students around, breaking bad news can be very challenging. So rather than just saying, well, I have to do it better, but having them think through what will be their goal, when they'll start working on it, what resources they plan to use, like are there videos they can watch, are there, a skilled faculty that they can sit in on and watch. Because as we know with skills, it's not just reading about it. You've got to watch and then practice it. And then how they will know that the final bit, how will they know that they've succeeded? What will be their measurement factor? Will they have a faculty person come and observe them again? Will they record themselves? What means will they use using that example? And what we've learned through it is that we've learned a couple of things, that opportunity for reflection seems incredibly important for physicians, for students, for residents, for other health professionals, as the model is being used by nurses, by dentists, social workers as well. And they're all finding that time to pause and reflect is valuable. I think for faculty and facilitators, what we're finding is that, or what they're finding, is that that coaching is the most challenging bit. Because I think as health providers, we're all doers, and we just want to tell people what to do and get on with it. But this notion of trying to help people decide what it is they have to focus on and how they're going to do it and what resources they need and how they're going to carve out the time to do it and plan for it is much more challenging for faculty. So, and I know, Lara, you've been involved too in faculty development around this and helping them to become facilitators instead of tellers, of telling people what to do.
It's interesting you commented about self-assessment, and sometimes people's self-assessment doesn't match, as you say, with what the feedback would be from others. What is your understanding of physicians' ability to self-assess and the role of self-assessment?
Well, that's a good question. I think, we all, I'm not a physician, but I think we and, health professionals and physicians generally think that, we're pretty good at self-assessing. However, in some of the studies that we did around self-assessment, and we did studies with physicians to ask that question, the question that you're asking me, to find out, like, how do you self-assess? How good do you think you are at it? And some physicians told us, well, I'm always collecting data. I'm always talking to my peers. I'm always learning from my patients. I'm always looking things up, and that that I'm always taking in information and trying to weigh how I'm doing compared to my peers, what my patients are telling me. At the other extreme, we had a couple of physicians tell us that, well, my patients, I've been in practice for 30 years, and my patients keep coming back to me, and therefore I think I'm doing pretty well. However, when you consider the shortage of physicians and so forth, that there's all kinds of other factors. So what we learned is that, again, this has led to my interest in being able to provide performance assessment data, is that often we're not as good as we think we are, whether we're physicians or teachers or researchers or whomever, whatever role we're fulfilling. And so then trying to provide that data and to do it, as I'm sure you and listeners know too, it's very important to have a safe environment so that folks can feel, professionals can feel safe to say, well, I don't know that. Because one of the incredible stressors and pressures upon physicians is that need to appear competent, whether it's to appear competent for their patients or just to do the work that they have to do. They have to appear competent, or to appear competent for learners. And so being able to back away from that and say, well, maybe I don't know that, or maybe I didn't do that as well as I could have, can be challenging. So an important part of facilitating accurate self-assessment is to provide that space and to provide the resources for them to be able to, actually see how they're doing, to look at the data. And if the data doesn't confirm their own self-assessment, then to have that conversation around, well, why do you think that's happening? What might have been going on in your head, or what might you have been missing, or so that just having not having a blaming conversation, but just an open conversation. I guess the basic thing is to be curious in some of these difficult conversations. Just to be curious. Well, can you tell me more about how you thought you were doing that, and why you were so surprised by this performance data? I'm just curious. Can you tell me more? And then once we know a little bit more about that, then we can begin to move on to the next step. And that seems to be an approach that has worked well.
So you say about how it can be challenging. What advice would you give to leaders who want to improve the performance of people that report to them or that they work with?
Well, so what advice would I give to leaders around improving performance? I think, first of all, have a safe, open environment, a safe context where people feel comfortable saying, I don't know, maybe I need some help, where it isn't an antagonistic environment. Having a process that's open and transparent for collecting performance data and for providing that data. What we found, as I'd mentioned earlier, is having someone perhaps trained in being able to facilitate these conversations and in learning coaching skills, so that people can be encouraged to use their feedback. What we've often heard, and in one of the earlier studies that we did when physicians had formal assessments, if they thought it was okay, or even if they didn't think it was okay, they would just sort of put it in a bottom drawer and never go back and look at it. But when we went back and interviewed them, and they pulled it out again, and we sat down and had a conversation about it, they said, oh, yeah, I can see that. I could make that change. Or, oh, yeah, that's really helpful. Now I understand why I got that score, and now I can go on and improve it. So one of the biggest learnings has been about having that facilitated conversation by someone who is most interested in improving the physician's practice. And sometimes that isn't always the department head or the division head, because of the conflict of roles there, and that it may be helpful to have someone else in the department do that, or have a facilitator, a trained facilitator on within the department or within the Faculty of Medicine to help hold some of these conversations, so as to remove any of the threat that could be felt if it were one's department head having the conversation.
It's an interesting idea. So if you were a department head, you might reach out to a colleague how would you?
I might reach out to a colleague or reach out to someone in medical education, for example. And I guess what I would really encourage department heads and leaders to think about is to become more conversant with coaching skills and in enabling themselves or one or two faculty members who are interested to become skilled in developing these coaching skills, as it has been shown that when the coach in there, I won't go through the coaching skills now. They're outlined in papers and so forth, but utilizing those specific coaching skills can really help physicians improve their practice, and residents and students, and they're not necessarily intuitive, as I mentioned earlier, but they are skills that can be learned, and so that would be one of the encouragements that I would give to leaders would be to either learn these skills for themselves, or to select faculty who are interested in their department in developing these skills.
We had Laurie Campbell on the show here. She's one of the people who works in physician performance at the Health Authority, and she was talking about coaching.
Ah, yes. Yes, I think I've met her, and yes, that she's sort of online with this. Mm-hmm. So I think that has been, having that safe environment, a transparent process, and focusing on that, we all can improve, and that we can all improve together, and being open about that approach as well as the coaching skills.
Thanks a lot for taking the time to speak with us here today, Joan. Any final thoughts?
A final thought, one that I had when I was driving in, was that I think I may have been a little bit removed from actual practice, but my sense is that practice has changed quite a bit sort of since COVID over the past few years. A lot more, virtual care. I hear of a shortage of physicians, a number of patients, a number of people who don't have a family physician. And that care seems to be almost more episodic, that it's the idea of family physician who sees patients from birth to death, more or less, whatever, has gone. And I say that lightly, but however, I'm a firm believer in having that longitudinal view of a patient's condition is very helpful and can save the system a lot of money if there's someone who's knowledgeable. So I'm just, and this would be a topic for another day, but I'm just curious as to how, if research is being done to study how physician practice has changed, and what the impact of that is on their learning needs. It's a curiosity of mine. See, I've turned the tables around.
So even in your almost retirement or whatever stage you're at, there's lots of questions that still engage you.
Oh my goodness, absolutely, yes. Yeah, because you really want the best. You really want the best for healthcare providers. You want the best for patients, and it's a complex time right now. So that's where some of my questions come from, for sure.
Thanks so much for joining us, Joan. Much appreciated.
Well, my pleasure. Thank you.
And that's another episode of Leadership PRN. If there's somebody you would like to hear me speak to, or a topic you'd like to hear covered, feel free to reach out to me at lara.hazelton@dal.ca or lara.hazelton@nshealth.ca. Until next time, take care.